A warm good afternoon. Sorry to stand in between your lunch. Actually, I was informed that whether I can give the lecture before lunch or after lunch. I said anything is okay for me because I had a very good snacks in between. So I suppose you are also comfortable. So the topic given to me was strategy for implementation of Siddha system of medicine evidences in preventive and promotive healthcare. So yesterday I was just skimming up to prepare my lecture. It was so good that within a half a day I could review whole literature. I can get back to the various research engines and I could get the references to prepare the lecture. I just was thinking back in 2004 when I started my research career as a research associate. It's not that easy. The research articles were not that accessible. You are in a golden era that you can access in a minutes, hours. So please make use of it. I would explain how we used to access. I was a research associate posted in Maulana Azad Medical College in New Delhi. So I had a very good access to the National Medical Library, NLM. So if I need to prepare a slide set or if I need to prepare a concept, at least I need to spend 1 week in the NLM library. So just to note down the references what I need. After that 1 week, I need to make sure that how many pages are there. Then I need to inform the caretaker that I need these pages. These are the number of pages. Then I used to take a Indian postal order for that amount and then give it to my attender. So he will be after that papers for another 1 week. For another 1 week to get those references, picking each one and getting it photocopied, and it normally takes 2 to 3 weeks to get all the things to prepare a concept or a proposal or a slides. But now it is not that much cumbersome. It's very easy. Please make use of these advances. It will be very helpful. So going into topic, I will go in reverse order. So what is preventive and promotive healthcare? Then evidences of Siddha system of medicine. Yeah, please. Just a second.
May we now humbly invite Professor Dr. M. Logamanian, former Professor, National Institute of Siddha, to chair the session. We also request Dr. T. Anandan, former Assistant Director of Siddha Central Research Institute, to chair the session, please.
As I told, I would be going in a reverse order, so I would be taking care of these topics. First going into the preventive and promotive healthcare, then evidences of Siddha system of medicine in public domain. So I am emphasizing in public domain. Third is strategies for the implementation. Why do we need the preventive and promotive healthcare? It's simple. We are just focusing in controlling the risk factors as well as preventing the disease early well in advance. This, I think pointer will not work in LED. So it actually saves time, money and resources and the stress dealing with the disease. So you are dealing with the people who are early, before even risks are identified or before any symptoms have come up. That is one of the good part of this thing. See, the India's population is growing, one. The life expectancy is increasing, second. The both of these two things are going to contribute as a growth of population and distribution over a period of time till 2050 or 2100. If you see, the elderly population is increasing from 5% to 15% by 2050. At the same time, your productive population increases from 48 to 59, around 12% jump. The same jump may not be occurring in the healthcare or the infrastructure. So we need to cater to the increasing population, to the increasing aged population in a way so as to focus on preventive as well as promotive healthcare is very primordial over here. So where are we going to apply? It's basically the preventive healthcare is we are going to apply in preventing the disease, whether we are going to prevent the risk factor or the early diagnosis of the disease or prevent the disease. So we have different levels, primordial, primary, secondary, tertiary. So I am just going step by step so that you need to know where to apply, because it's very simple. Like my previous speaker said, you need one spark, one idea to go forward. So if you take, I have around 60-65 publication, I can mention 2-3 things, 2-3 highly cited articles in that is very simple ideas. Why can't we treat this disease instead of 6 months, 5 months or 4 months? Why can't we treat the disease, acute disease, with the drugs of chronic disease? Now I have a child shortening treatment, it is also the same. Why can't we treat the disease which are in minimal, treat the disease instead of 6 months, 4 months. So these are the small ideas and spark which you need to catch up and go for a big proposals. So primordial prevention is before emergence of risk factor, you need to intervene and educate the population by individual education or by IEC, mass education. Primary prevention is risk factor is present but no disease is there. So basically this is done by vaccination or immunization, specific protection, lifestyle modification, sterilization or sanitation. Secondary prevention is mostly these patients are asymptomatic. You are diagnosing them, and the early diagnosis and treatment warrants their arresting the progression of disease. So basically this is taken up in the master health checkup or targeted health checkups. Secondary prevention is basically happens in diagnosed patients where you arrest the progression of the disease, like rehabilitation, disability or disease limitation. Promotive healthcare is very simple. You are just going to aim on the objective of having a good quality of life. So which promotes health by healthy lifestyle, infrastructure and healthy environment. So whatever we have dealt, if you see the target population is very hard to manage target population. They are not simple, because when health seeking behavior is a primordial thing, why the patient comes to the doctor is he has a symptom. Here you will be dealing with the asymptomatic patients or the participants. So they are not patients, they don't have the symptom, they are asymptomatic. Second, they are apparently healthy. I am healthy. Why are you teaching me? Why are you doing this? Why are you vaccinating? Because this same thing we had many sessions on when we went for COVID vaccination, when we went for TB vaccination within the household, which I am now dealing. Tomorrow I have a presentation for 1 hour on our work on 5 years of work on TB vaccine amid the COVID pandemic. So it's very difficult to convince these people, these set of people who are asymptomatic and apparently healthy individual, to make them into your ambit of to listen to you, to test for you, and to deal with them. So, and main thing is they have their own personal preferences and values and beliefs. Because we know how the resistance during the COVID vaccination or TB vaccination we had their own beliefs, their own personal issues. They vaccinated for one dose, but on the second dose they denied, third dose they denied. Attached with local culture of the community. Yes, for example, we are doing a survey of TB in the north. They thought that we are going to give a vaccine or eliciting symptoms for the COVID. Then apparently many villages said they don't have even cough as a symptom. So low health seeking behavior as well as difficult to follow up and retention because they are apparently healthy and asymptomatic. So this is the very issue with the target population. The population we are targeting is asymptomatic and apparently healthy. They are not going to come to seek any health issues as they are asymptomatic. So for them to convince, you need to have a very strong strategy. You need to have evidence-based publications in your hand, and that should speak for you, because these are people who are very well educated. Because now the patient, we are dealing with the patients in Chennai as well as Tiruvallur in Vellore districts for the TB vaccine study. The education level as well as the knowledge of the patients are very high, even in rural setup. They come to you after Googling everything, and they will pose you a question very hard to crack, not questions which you need to be prepared to answer them. So you can only answer when you have the evidence-based evidence for that. You can't just say it is used, it is in classical, it is in 1500 years or 2000 years. Yes, we know that. But we need to make it and get it fast forward. Effectively communicate this information. It's very important, because yes, you have the evidence, but second is you need to effectively put down your argument to the person who is equally knowledgeable, and just step down to him and go in his narrative and convince him. And it is very difficult, and it takes time also. So you need to, first time you need to work with the patient when you are dealing with the preventive and promotive healthcare, because first time they will come. If you are not putting enough time and effort in the first time, the patient you cannot retain for the second time or further follow up. Because I am having a TB vaccine study where we give vaccine and follow up for 3 years. It's very difficult to follow up. 3 years follow up. So here you need to generate an evidence. So then effectively you need to communicate and make sure that he or she understands what you are contending to say. Third one is, please take a shared decision making. So never boss on him. So because as I said, the individual has his own belief, his own preferences. Please respect them voluntarily and make sure that your thing is taken care, as well as his issues of preferences and the culture is taken care. For example, I will just explain you. For example, we had a SHINE study which they were telling, we had just taking the sample of hair to estimate, child's sample of hair to estimate the anti-TB drug. It's very simple. In a child to take a blood is very difficult. In a child to take a hair and to estimate the anti-TB drug is very simple. Do you agree? Yes. So we had this thing in the proposal, but we had 5 sites. It's an international study. We had 3 sites in Africa and 2 sites in India, and our sponsor was UCL London. It's very simple study. Everybody agreed. We went for the study. The first resistance came from the community from Africa. They said, you take even 20 ml of blood from my child, but I will not allow one hair to be plucked. Because it is the local constraint, local issues, local beliefs are there. So we cannot go forward. So always go with them. Then we had a meeting, stalled everything. We had two sides, they agreed after counseling. One side, IEC, they scrapped that. It's very simple thing, but the local beliefs, like they had some voodoo and everything, the local beliefs were there. So they never came up for that portion of the study. That sub-study was deleted in those sites, and we did very fortunately. So, ever you have a shared decision making with patients' preferences and values, to have a long rapport with them. So for these strong strategies, you need to have a evidence-based medicine. So I am very glad to know that Jagannathan sir said, you publish, we will help. I haven't heard for 20 years in my research career. I have spun across 5 institutes, 5 organizations. No, still now I go pillar to pole to hunt for the registration charges. It gets delayed. At times I give up. I couldn't do that, sir, because my mentor said never fund the research. Research cannot be done by an individual person. Research is a team person, and research is done by an organization. So that should be. Never put any money into the research, because then you will really think, I have put the money and I should. No, you should never fund, because my publication fees spans from $1,000 to $2,000, which is equivalent to my salary. So I cannot fund myself to these things. So I really congratulate sir. Even we are not fortunate till now to get those fundings. So I would request Muthukumar sir to like 270 abstracts has come up. So he told that 270 abstracts. I request those 270 abstracts to be peer reviewed, and the abstracts should be put into the Ayush research portal. That is one request. And second is, out of this 270, if 10%, 27 goes into the index journal, and they will really, they have come forward to help you. I suppose in another year we would have 27. It's a big number. I would say why it is a big number. So evidence-based medicine is about systematically reviewing, appraising, and using clinical research finding to aid the delivery of optimum clinical care to patients. So if you see the hierarchy of evidence and public search strategies, meta-analysis, then systematic review, RCTs, cohort studies, case control studies, they have the weightage. So as I said, where the Siddha system of medicine and prevention stands. So yesterday I just went into the search strategies. I went to PubMed. So in PubMed, just to, if I type like this was last night around 11, 12, I was preparing my slides. So this was the idea came up. Suddenly I just so there was Siddha word is there in 4671. Siddha and prevention, if you put 727 articles there from 1968 to 2024. Then I picked 10 years, last 10 years, 349 articles, out of which 2 were meta-analysis. The word Siddha was there, but it was referring to the Ayurveda, drugs and diseases, so meta-analysis was not there any. Systematic review, 10 were there. I went in detail because everything I need to go in detail. So I was like preparing, and I engrossed into this thing, and I went late sleep. So then I found these are the areas where I could find Siddha, like oral lichen planus, COVID-19, coconut oil in oral hygiene, and Triphala. Then I went to clinical trials, 14, and RCTs around 8. Half of them were not Siddha. Then only one lead I got is Kapasura Kudinir in COVID-19, which my previous speaker was saying. Okay. So I said, okay, this is a PubMed is international thing. We are not getting so much. But I know this is a Ayush research portal where I am also a part of it. When I was working in Central Council for Research in Ayurveda and Siddha, erstwhile in 2009 onwards, then it bifurcated. However, I do search whenever I get something, I go here because I am also a member of IEC also. So whenever I get proposals, I do these two searches to take some information before I can judge these things. And to be silent, and I ask others also, what is this, what is not that, because I may be wrong, I may be inferred very differently. So yesterday night, I went there also. So total Ayush abstracts are that 42,205, out of which Siddha system has around 5,556, of which clinical research, if you take the domain, 688. If I put prevention in all clinical research A, clinical research B and clinical research C, I got 35 articles or abstracts, out of which mostly they were therapeutic, no prevention. But these two were found as prevention, that is Kapasura Kudinir and Nilavembu Kudinir, precisely said by my previous speaker. So, we need more clinical studies as evidence-based for implementing preventive and promotive health care. As I said, these are hard to address asymptomatic participants, apparently healthy participants. For them to address, yes, you need more evidences. Yes, we have age-old evidences. Very fine. Please advance those evidences. I don't have the opportunity of getting the publication fees. You have the opportunity giving in upfront. Please use them. Publish it in a very good journal. Yes, it takes a lot of time. Please bear with, go. For example, we did, for your information, we did a 10-year study in TB lymphadenitis when I joined ICMR. We wrote the manuscript. It has going on and on for past 1 year, but still under review. I know it would be having another 1,000 or 2,000 as fees. I'm ready to go and press my officials to get that. Please don't give up. It is a long story. When it gets concise, you see that, oh, okay, they have done this and that, but it takes all over this. So please make sure it is published, everything is published. So my third thing, what are the types of studies? You already know that there are observational studies and experimental studies. In observational studies, you observe both exposure as well as outcome. In experimental studies, you have already the exposure. You only observe the outcomes. That's it. So the clinical studies which give you evidences where you can generate evidences in preventive and promotive healthcare is case report and case series. Even though they are down, please do not neglect this case series and case reports. I haven't seen these things, but I am sure many would have done a case report, a single case report, 5 cases of case series. You might be having. Please make it public. Make use of the fund. Each one of you, I am saying, so if after a year, if I am going to put a search in the Ayush research portal or PubMed, I should see a hike. So that hike will be brought by you only, not by others. So the case report series or cohort, it's very simple. My first publication in 2006 came out of a cohort which was maintained for 20 years by my mentor. He maintained a cohort of 20 years, recorded everything. So integrative healthcare, this is inevitable. Health-seeking behavior will make you to integrate. It is not the government or the any official is going to integrate it. Health-seeking behavior of public will integrate. So already it is integrating. We just passing through unaware. Please get the information, document it. For over a period of 1 year, 2 year, 3 year, you can have a case series, even cohorts study reported from this. When a patient walks in for an ailment, make sure his history is taken. You record everything from where he is taking allopathic drugs, what are the investigation. Please record, please take photocopy or Xerox of everything, whatever. Just you just collect the thing. It takes years. But if you have collected everything from all, because they are mixing everything, and whether they are coming up with a good result, you only need to analyze and say. Document all clinical findings and interventions carried out, and continue recording over a period of time. Analyze retrospectively. If even one case report is there, kindly try to publish in an index journal. Make use of the evidence-based medicine. Coming to the next is clinical trial. It's my very dear to heart, but it is a very time-taking, very expensive. For example, now I have a TB vaccine study which is ongoing for past 5 years. I have got a funding for 4 sites around 10 crores, and we have 18 sites. You could imagine how many crores are there into the vaccine research. So it's a time taking, but small things you can plan, like case series, case reports, and cohort studies, you can very well plan. These are for established institutions and research organizations to have and put your resources into the clinical trials, whether it is uncontrolled or controlled, and better go to the RCTs. So control is nothing but a placebo if there is no standard of care. If there is a standard of care, go in comparison with the standard of care. And whenever you are using a placebo, make sure that the placebo is of same color, same structure, size, shape, odor. This is very important, because we have made some placebos when we were dealing with the CCRAs with Ayush QOL, 2C, Ayush QOL, etc. So it's very, very difficult. You need to sit with pharmaceuticals and make exactly those placebos for blinding purpose. Then stratify based on age or severity, so that you have equal number of people in both the arms. Then the black randomization to have equal number at any point of time. Blinding, you all know, it's an open label, means everybody knows what the patient is getting, what I am giving to the patient. Single blinded, patient doesn't know. Double blinded, patient as well as myself don't know. For example, now I have a TB vaccine study of 3 interventions. One is vaccine A, second is vaccine B, third one is placebo. So it is a double blinded. I don't know what I am giving to the patient, and patient don't know. But the cover back to me, they know. The pharmacist knows, as well as the analysis person who is going to analyze also knows. So, but triple blind is 3% doesn't know. Everything is centrally done, and patient doesn't know, doctor doesn't know, and the person who is analyzing also doesn't know. So efficacy versus effectiveness trial. Efficacy is you have a strict inclusion-exclusion criteria done in ideal conditions to have an efficacy. Effectiveness trials are mostly done in the community level, at the PHC level, at the community, with the real world things. So you will have a compromised efficacy, which is called as effectiveness. So the prevention trials, you have 2 trials. One is the primary trial and primary prevention trial, and secondary prevention trial. It's very simple. Primary prevention trial just prevents the disease occurrence, and the secondary prevention trial prevents the disease reoccurrence in the deceased, already diseased. So why are we dealing with the whole preventive and promotive? So this is projected acceleration. This is a mathematical model for going for elimination of TB by 2035 as per the goals. So if we want to get eliminated TB by 2035, so we need to put what are the efforts. So you could see a box of red. So the line which is dotted red line. So if you don't put any effort, so there would be a reduction of 1.5% in TB per year over a period of 2035. Yes. Second is the blue line, continuous line. If we are going to use the tools available, the diagnostic tools, the drugs for treating the TB, then you will have a 10% decline of the TB by 2025 and further 5% up to 2035. The last red, you could see, introduce new tools like vaccine or new drugs. We need those things to achieve a goal of elimination, without which we cannot do it in normal way. So if we introduce a vaccine or a potent drug, you could see there is a 17% reduction per year from 25 to 35. That is what we are, like tomorrow I have a TB vaccine study presentation in another forum. So hopefully that is a double-blind study. I don't know what is, I am just presenting on challenges. We may have in coming year a vaccine or not, it will be in vogue. So next is collaborative clinical trial. This is my pet subject, and involve various stakeholders. Please, when you are doing a research, it's not your personal job. It's a teamwork, and it should be done with a very big team. The more you have the people in the team, you are more empowered and you will have more things to do. Involve everybody, give them credit. They will be happy and you will be having all the things which you want for the study. Collaboration between stakeholders here means different system of medicines need to be involved. One, and other sciences, physiotherapy, dietitian, physical medicine and laboratory support, everything, you involve everybody. Put them as co-investigator and just sail it, because even then it is not going to be a cakewalk. It would be very difficult for you. Integrative approaches for preclinical studies such as drug-drug interaction safeties, like for councils, I would suggest these things, and as well as clinical studies with drug-drug safety as well as efficacy is very important, because when you go into other big institutions like AIIMS or JIPMER, they will ask these things in the IEC, and you are well empowered with these knowledges and these backup documents to convince them, because it's very important. So EBM, the evidence-based medicine, enables patient to make informed decisions. One, and the decisions is based on the benefit risk, that is efficacy and safety evaluation. So potential areas where the Siddha preventive and promotive healthcare need to be focused is general well-being, immune boosting, geriatric care, skin care, musculoskeletal, neurological and NCDs like hypertension and diabetes. So to conclude, please publish guidelines with evidence-based, well-informed, with translation, use of knowledge translation tools like AI and everything to translate to a bigger population, and try to encourage everybody to have a measurable outcome and magnitude of effect, because that's only shows to the world. Because, like for example, yesterday I searched the PubMed and Ayush research portal to see how we are influential to the external world with the Siddha system of medicine. That is the only that is only the magnitude of the effect. So increase the magnitude of the effect. So that is my conclusion. I just wanted to just share a very simple thing just out of this topic. So this was a Blue Zone study done by Dan Buettner, a National Geographic explorer and journalist. What he did is he went to Okinawa, Japan, and saw their well-being and longevity. Everybody, most of the majority of them lived beyond 100 years. So he set to explore other parts of the world where the people are majoritarily living more than 100 years. So he found the blue zones in Okinawa, Japan, Icaria, Greece, and then Sardinia, Italy, Nicoya in Costa Rica, and Loma Linda in US. So all these 5 places he identified in a single line, that those people who are staying there lived more than 90 years or near to 100 years. So then what they did is, they put all the factors and they come up for, like, they choose one in Japan, one in Europe, one in America, and they put all these factors in a Venn diagram, and they saw that you could see at the center you could see the well-being of longevity is mainly of these 6 factors. That is, one is strong family contacts. Second, no smoking. Third, plant-based diets. Fourth, constant moderate physical activity with a purpose. So everybody had a purpose of living. They did a physical activity for that purpose. Fifth, they socially engaged with their peer groups in the evening or afternoons on daily basis. And last is protein consumption from plant-based thing. These are basic things which may give a longevity of life. Thanks. Thank you for your patience hearing.